Okay, fantastic. Maybe we can get started. So thanks everyone for being here on a Saturday. We appreciate your interest in CaMSIGN. Just a very brief background on CaMSIGN. Pedram, Mohammed, and I are very happy to seeing a new chapter for this year, CaMSIGN. And as you're probably aware, this is our fourth event of the Women in Neurosurgery series. We had the great pleasure of having Professor Zadeh in our Women's Day, March 1st, I believe, last year. We had some faculty and residents across Canada. We had a panel, U of T specific. One was on research, one was on maternity leave. And today we have the great distinct pleasure of having Professor Gelareh Zadeh today. Just to give you a structure for her talk, before I pass it on to my friends and colleagues, Dr. Zadeh will begin her talk with a more scientific background, and this would be followed with a more personal trajectory in her growth as a neurosurgeon-scientist and a leader in the field. So without further ado, I'm going to pass it on to Pedram to begin the biography.
Absolutely. Thank you, Salman. And it is, again, a very our utmost pleasure to be having Dr. Zadeh joining us tonight. So Professor Zadeh is the Dan Family Chair and Professor of Neurosurgery at the University of Toronto. She is the head of the Department of Neurosurgery at Toronto Western Hospital and co-director of the Krembil Brain Institute at University Health Network. Dr. Zadeh is a senior scientist at Princess Margaret Cancer Center, where she runs a translational research program at MacFeeters-Hamilton Neuro-oncology program and holds the Wilkins Family Brain Tumor Research Chair.
Dr. Zadeh has dedicated neuro-oncology and a skull-based practice, which includes a number of multidisciplinary specialized programs, including a skull-based clinic, brain metastasis, pituitary clinic, and neurofibromatosis clinic. In parallel, she has an active research laboratory focusing on integrated multi-platform molecular analysis of brain tumors, together with a focus on understanding molecular response to targeted therapies such as anti-angiogenesis and metabolic inhibitors. She is also involved in a number of national and international organizations. She was also president of Society of Neuro-oncology and the past chair of Neuro-oncology Committee at the World Federation of Neurological Surgeons. She's the co-chair and founder of the International Consortium on Meningiomas. She's the editor-in-chief of Neuro-oncology Advances, Open Access Journal of SNO and EANO. It's a great pleasure to have you here, Dr. Gelareh Zadeh. The stage is all yours.
Great, thank you very much. Can you hear me okay? Okay, thanks again for the invitation and the fact that you've taken the Saturday evening to be here. Hopefully we can make this interactive, so feel free if you want to stop me to ask a question. I thought I would do the first half on a topic of research that's been an area of interest to me, and it's growing in our lab, for you to see some of the work that we're doing, and then maybe focus the second half on some of my experiences about mentorship and how to really help yourselves in your careers as you advance. So I don't have any conflicts that are related or unrelated to this talk. I do have a disclosure that, as mentioned, I'm the editor-in-chief for Neuro-oncology Advances, which is an open access journal for neuro-oncology, and the Society of Neuro-oncology and the European Association of Neurological Neuro-oncology. I'm just going to put my phone here, but somebody has to alert me to the time if I run over. I'm proud I took over the Dan Chair and Professor role September of 2020, so just over a year ago. And it's really an honor to have this position in the 100 years of neurosurgery at University of Toronto, which will come up in 2023. I will be the first female to have taken this role. And similarly, it extends to Canada. So it's really an opportunity for me that I see for leaving an impact and legacy and a mark on the department. But most importantly is that we have a number of amazing faculty, nearing 30, and each of them are recognized in their own way for the work that they do in their field. The number of brain tumors that we get, if you look at the WHO, the World Health Organization that classifies brain tumors, is over 150 different tumor types. but we don't deal with 150 different tumor types on a regular basis. The ones that we see commonly in our practice, in particular for me, I'm one of the skull-based surgeons in our university, are pituitary tumors. This is a pituitary macroadenoma. As you could see from its size, it's giant. It pushes the optic nerves and chiasms very high up and causes loss of sight and impairment in vision. It's an operation that I could do endoscopically, endonasal, through the nose, not having to open the brain, and remove this tumor completely and restore the patient's sight, which is a really very rewarding experience. And the patient's tumors are benign and they have a good outcome generally. The other tumor that we have a lot of interest in my lab are meningiomas. These are tumors that are growing very fast in numbers as the incidence rises, and I'll show you some of the statistics for that. Typically, they are cured by surgery, and currently the main modality of treatment is really surgery. There aren't any other chemotherapeutics or targeted treatments that can help with control of this disease. Another brain tumor that we commonly deal with are acoustic schwannomas or vestibular schwannomas. It stems from the vestibular cranial nerve. And there's been a shift in practice on how we manage vestibular schwannomas, in that this is a scan of a patient with, as you could see, the small dots on the side, a frame on their head, because then it turns the patient's head into a 3D dimensional structure. And using computer-generated programs, we can target the tumor and spare the normal brain to be able to give it focused radiation. And that is the main treatment and the most recommended treatment for acoustic schwannomas currently, taking us away from surgery, as the surgery is associated with high morbidity. And so leaving it really to surgery only when the tumor is greater than 3 centimeters. The tumor that continues to evade us are glioblastomas. You may be familiar with these tumors. Most recently in the popular news, there are a number of people who've been diagnosed, unfortunately, with glioblastoma. They're tumors that at the time the patient presents, though we could see a critical mass, we know based on scans and based on postmortem cross-sections that although the surgeon can remove this mass safely and with almost near complete resection, the problem is not so much this mass, it's the cells that have invaded beyond that mass and are causing the trouble for the patient, because they're invasive cells, they're resistant to treatment, and they tend to cause recurrence to the point where the patient passes away within a 12 to 18-month period. And we use adjuncts to improve surgery for maximizing the extent of resection, such as a patient being awake and doing intraoperative stimulation. I have the consent of this patient to show the scans, but they still continue to have a poor prognosis. And a lot of research in the field of neuro-oncology is dedicated to glioblastomas. I thought, though, for the purposes of this evening, I'll show you some of the work we are doing on meningiomas. They can occur anywhere in the brain. They could be well-defined and resectable by surgery with minimal effect to the patient. They could be very aggressive, wrapping around major blood vessels and cranial nerves that go to provide function for the patient. And so either the surgeon is pushed to leave a residual, or by removing it completely, the patient is left with a deficit. So of course we avoid a deficit and have to leave a residual. When we look at meningioma statistically, we could see that if you look at all brain tumors, and this is based on the CB Trust repository of data that's created every year, published in Neuro-oncology, an excellent body of work that's created by the CB Trust, we could see that majority of the brain tumors, in fact, are meningiomas. And although a lot of the research is focused on glioblastomas, given their devastating outcome, majority of the tumors are meningiomas. And if you remove the malignant brain tumors, what's defined as malignant, and look at only those that are left behind, meningiomas are more than 50% of the tumor. So this resulted in us building an interest in meningiomas to a formal level, and I started what's called ICOM, International Consortium on Meningiomas, bringing together a number of sites across the world, more than 30 institutions, to be able to focus on increasing awareness of meningioma research advocating for meningioma research to be able to get dollars that contribute to better understanding the biology of meningiomas so we could treat patients better, because there's a dearth of research and understanding of meningiomas currently. If you look at the incidence of all brain tumors, you could see that past age of 65, there's a sudden increase, a sharp rise in the number of meningiomas that we could see compared to other brain tumors. If you look at the world by population, you could see that majority of people, in fact, are going to be over 60 in 2050. And so the population is aging because we're able to control systemic diseases very well in majority of the world. And so as a consequence, there's an increase in the number of meningiomas that we see in our practice. So there's a practical need to actually better understand meningiomas so that beyond surgery, we can offer additional treatments. One of the methods that we rely on in medicine for better understanding tumors is to rely on the World Health Organization grading system. The grading will tell us how aggressive the tumor is, what's the likelihood of it recurring, and what do we need to do in order to then be able to distinguish a grade 1 from grade 2 and grade 3. If you look at meningiomas, the reason they're referred to as benign is that by definition, anything that's cancerous will be grade 4, and no meningioma is ever graded as grade 4. They're either grade 1, majority are grade 1. They're grade 2 if they have certain features under the microscope when the pathologist reviews the sections that we send from tumor samples in the OR. And then there's grade 3, which is almost precancerous. They're called anaplastic meningiomas, malignant meningiomas in some of the literature. And the distinguishing feature between a grade 3 to a grade 2 is the number of mitoses that they see, so cells dividing under the microscope. If there's more than 20 such cells compared to more than 4, that distinguishes grade 3 from grade 2 and equally from grade 1. What's a bit fascinating about meningiomas is under the microscope, they can appear 18 different types. Some of them are aesthetically pleasing. They have these very nice recurrent patterns. Some of them have whorls, they're chordoids. And some of them have distinguishing features that the pathologists become very well versed to being able to tell you whether they're microcystic versus chordoid, for example, versus angiogenic or other. None of these, however, tell you whether the patient's going to have the tumor come back faster or slower. So in other words, although under the microscope they may look very different, it doesn't mean much for the patient as to whether the tumor is going to come back and grow more aggressively. The other classification that we use as surgeons is called Simpson Classification. Simpson was a surgeon in Australia that more than 3 decades ago thought of introducing this classification, which we still use to date. And although very crude in some ways, it's still quite relevant. If the patient has a tumor and the surgeon is able to remove the full tumor, including the covering of the brain, which is the dura, presumably that's where these tumors come from, any abnormal bone that's associated with the tumor is drilled, we are able to achieve a gross total resection. If there's some tumor that's left behind, for example, on the covering of the brain, the dura, because we can't actually reach it by surgery, it's a grade 2 gross total resection. So the likelihood of a recurrence of a grade 2 is slightly higher than a grade 1. And grade 3 is when you're not able to remove the tumor in completion, and there's parts of it left behind because you wanted to preserve a vessel or preserve a nerve or preserve a section of the brain. And so grade 4 and 5 are where you've had partial resection or a biopsy. And of course, as you anticipate, those that have a subtotal resection, because a significant amount of the tumor is still left behind, have a much higher recurrence rate. So the WHO classification that I showed you on the previous slide and the Simpson grading is what we use in clinical practice to determine whether a patient has an aggressive tumor that's likely to recur, or perhaps has a tumor that will behave in an indolent fashion. So after surgery, no additional treatment is required. However, if you look at our own practice at University of Toronto, at Toronto Western, if you look at grade 1 meningiomas, it's not true that they all have no recurrence rate. In fact, there is a higher recurrence rate for grade 1s. There is some population of them that tend to recur. So meaning, although WHO grade 1 meningiomas are considered to be benign, and after surgery, the likelihood of recurrence is low, you could see that there's some of them that actually act quite aggressively. Grade 2 meningiomas, we always believe they're a more aggressive tumor. They tend to recur faster, but then there's a subtype of them or a subset of them that don't behave so aggressively. And in fact, their time to recurrence is very high. And then grade 3, which are the malignant meningiomas, if you recall, the anaplastic, the precancerous, we always assume that they recur very fast and they require radiation. However, you could see that there's a subset of grade 3 meningiomas that may not recur very fast. And in fact, the longevity following surgery is much higher than expected. So what does this tell us? It tells us that although WHO classification that I showed you is roughly good at predicting the outcome for the patient following surgery, and the extent of resection with the Simpson grading is good at determining rate of recurrence and rate of growth following surgery, they're not precise. There are some populations within each category of the WHO grade that fall at either end of the spectrum. And it's really that population, the ones that don't behave under the bell curve, that we'd like to identify. The way we go about this in the world of cancer biology or tumor biology is to look at then genomics and epigenomic alterations that occur in a tumor that perhaps can tell us whether a tumor is going to be aggressive or maybe they will be not as aggressive. For example, in the world of gliomas, the invasive glioblastoma that I showed you, a mutation that was identified approximately 2 decades ago is in the isocitrate dehydrogenase enzyme. If IDH is mutated, the patient with a glioma will do much better than a patient whose IDH is wild type. So with that understanding, the literature, if you look at it, the researchers thought, perhaps we look at the mutational pattern of meningiomas and see if there is a mutation that can determine aggressive behavior versus benign. So approximately 2 decades ago, these studies were done. At the time, they were seminal papers. They were landmark studies. There was over 800 samples analyzed from grade 1 meningioma, grade 2 and grade 3. And recall again, grade 3 are the precancerous, grade 2 are the bad actors, and grade 1 are the benign. There's mutations that you could see in NF2, which is very well recognized. It's the long-standing recognized mutation that's present in meningiomas. You could see in grade 1, there's about 45%, and with increasing grades, there's a little bit of an increase in the percentage of NF2 mutation that we see, possibly speaking to a more aggressive phenotype. There's other mutations that were found, but interestingly, the other mutations that are occurring at a recurring rate are only in grade 1s. So unlike gliomas, where I just mentioned, the IDH mutation tells you that the patient does better versus does poorer, recurring mutations are not seen in grade 2s and grade 3 meningiomas. So perhaps there's something beyond mutation, so beyond exome sequencing, that tells you the mutation signature that we need to do to analyze the meningiomas to understand the biology of the tumor better. There is an increase in copy number alteration. So if we have the short arm 22q loss in grade 1s, you could see that the percentage increases in grade 2s. 1p, the long arm of 22, the 1p short arm of 1 chromosome number 1 increases with increasing grade. 10q increases in grade 2 and then subsequently in grade 3, and similarly 14q. So copy number seems to reflect increase in grade to some extent. The other thing on the bottom line you could see is TERT promoter mutation. Can we use these in clinical practice? To some extent we can. We can use these analyses to then distinguish a tumor of more malignant aggressive behavior from the other. There was a seminal study that was published in Nature by a group in Germany, the DKFZ group. Methylation signature was used. They had over 3,000, in fact, tumors that they analyzed by what's called methylation, using DNA methylation on an array-based analysis to see whether the tumors in the brain have unique signatures. And what's really quite fascinating is that all of the brain tumors, I told you there's over 150 WHO, World Health Organization, brain tumors, you could see that each one of them has a very distinct methylation profile, as you could see on the screen, akin to a fingerprint, to the point that if you in fact took a tumor from a patient and did methylation analysis and plotted it on this graph, you can use that methylation signature to say what kind of tumor the patient has. So this is a huge advance in understanding tumor biology, and also more importantly, helping with the diagnosis of brain tumors. We looked at methylation signature of meningiomas to say, well, if there is a distinct methylation signature, can that signature be used as a predictor of outcome for the patient? And the way these studies are done, you have a test set, which is your original data set, for example, from our institution. In this case, the test set was from MD Anderson. It's a study that we did in collaboration with MD Anderson. And then the results show here, if you look on a heat map, of all the meningiomas, here's the WHO grade 1, 2, 3. And then looking at the distribution of methylation, it divides itself into high methylation signature and low methylation signature. On the heat map, you could see very clear distinction that's independent of the WHO grade. You could see the WHO grade are in different colors, and it's independent of the WHO grade. So you see that meningiomas, independent of the histopathological grading, have very distinct characteristics on methylation. Is it associated with an outcome that's favorable and unfavorable? And you could see here, the blue line shows a very favorable outcome on the Kaplan-Meier survivor curve, whereas the red shows an unfavorable outcome, meaning that they speak to a population of meningiomas where the outcome is poor. We then repeated the same analysis on a validation cohort, which was the University of Toronto, a Toronto Western cohort, and we could see that the methylation distinction between the favorable outcome and the unfavorable outcome is reproduced, and so validated our own findings to make sure that there wasn't something unique about this original tumor population. At the same time that we did this study, a second group, the same group that published on the methylation classifier that I showed you in Germany at DKFZ, demonstrated the same concept. They, however, divided the two groups into more distinct subtypes, group 1, 2, 3, that are benign, so possibly are a favorable outcome, an intermediate group of group 1 and 2 methylation, and a malignant group. With each of these groups, you could see that the patient has a very distinct outcome. You can argue that perhaps the first 3 are comparable, the second 2 are intermediate, and the third is really bad. So although it adds to the classification that we saw based on methylation for meningiomas, you could also see that it's the same concept. Methylation supersedes and is able to better predict outcome than the WHO classification. And more importantly, if you look at the mutation signatures that I showed you earlier on the slide, it's independent of the mutations. So with that, we thought, well, what does this mean for an individual patient? Because if an individual patient has their tumor taken out and it's benign too, where on the curve do they fall? More importantly, if you're a patient and you have an intermediate type tumor, where on the curve does your tumor fall? Because it's very different if you're at the bottom end of this Kaplan-Meier versus the top end of the Kaplan-Meier. So to personalize this, we thought perhaps we can use methylation signatures to refine the ability to predict outcome for patients in a 5-year period. If we take the cohort of meningiomas that we have at our institution, you could see based on grade, there's grade 1 that does well, grade 2 intermediate, and grade 3 that does poorly. But not all of them do equally. There's some that do very well and some that do very poorly within each category. If we then use methylation to predict outcome, independent of the WHO grade, you could see that the prediction of outcome based on methylation, although we saw two distinct groups, favorable and unfavorable, when we increase the cohort of tumors, we can change it to three groups: good outcome, intermediate, and poor. And so the question is, does methylation supersede WHO grade? So in order to do that, we looked at coming up with a predictor, a model of being able to convert the methylation signature for an individual patient to a pipeline, a computer-generated pipeline, through a series of bioinformatic analysis using the distinct 10,000 probes that are methylated between the good outcome and the bad outcome tumors, add onto it some patient demographics, including their age, the WHO grade based on histopathology, and the extent of resection, to see whether we can come up with a computer-generated machine learning algorithm that can predict the outcome for the patient. And in fact, we were able to do so. So independent of the grade, if you look at all WHO grade 1 meningiomas, generally majority of them do well, but there is a subset, as we've seen in clinical practice, where the methylation pipeline that I just showed you that we generated through computer pipelines can predict those that will act poorly and in fact have a very poor 5-year survival. Why is this important? Because if the patient that I have has a WHO grade 1 tumor resected following surgery, and I do methylation and I see that their outcome is going to be worse than what's expected, I will intervene sooner through imaging more frequently and perhaps considering radiation upfront. WHO grade 2, the intermediate group, are the group that are the most controversial and challenge us the most in our clinical practice, because nobody knows the right answer as to whether they should receive radiation or radiation can be deferred. So when we use the methylation predictor, there is a subset of WHO grade 2 that actually do very well, comparable to WHO grade 1. So I would argue that if the patient has a WHO grade 2 tumor, but they fall within this area of the methylation, we are comfortably able to monitor them and avoid radiation that has long-term detrimental effects on the brain for the patient. There is a subset of WHO grade 2 that actually do extremely poorly by methylation. And we would argue that this group must receive radiation following resection. And then the intermediate group warrants discussion at the tumor board to see perhaps whether there's a significant residual left, the status of the patient, and other factors that we would finally reach a conclusion as to whether the patient receives radiation or not. And then WHO grade 3 tumors are those that I showed you earlier do very poorly. Majority by the methylation predictor do poorly. However, there is a subset that in fact do very well. And this group would definitely benefit from not having radiation and having radiation deferred. So although traditionally most centers would radiate a WHO grade 3 meningioma, we would say that we would spare those that fall within this category. So this is how the predictor works. It's a calculator. There's 100 points weighed based on the methylation pipeline that I showed you. The extent of resection, the Simpson grade that I showed you, is approximately weighed at 20%. The WHO grade, the grading given by the pathologist under the microscope, is weighed at approximately 50%. So in a hypothetical situation where there's a grade 2 tumor, the patient has had a Simpson grade 3 resection, and the methylation predictor gives us a point of 60. Cumulatively, the score is approximately 90. The 5-year survival rate in our predictor model is 0.4, which is an inverse of that 60% of chance of recurrence in 5 years. And we would take that into account in our tumor board discussion. So these are examples of cases. This is a meningioma. It's classical in its appearance for a meningioma. This tumor is resected. The resection is good, and there's some residual left. So the extent of resection by Simpson grade is 4. The WHO grade was 2. The predictor based on methylation was a number that was produced based on the pipeline. The likelihood of recurrence is 0.09. So really the percent chance that there would be a recurrence is the inverse of this, a high number. And we could see that within 33 months, this patient has a very aggressive recurrence. And so they should have had radiation up front. This is a case pre-predictor that we analyzed again to see whether we could have accurately predicted this recurrence, and in fact, we can. This is a similar tumor, a meningioma. The resection is good, however, there's some residual. Simpson grade is 4, grade is 2 based on pathology, but you could see the methylation predictor score based on the pipeline is much lower than the prior case. And so the 5-year recurrence score is much higher compared to the prior case. The inverse of this says that the likelihood of recurrence is much lower, and 72 months later, with no radiation, this patient still has no recurrence, and so we can comfortably continue to monitor the patient. So this tells us that there is value in using the methylation in order to predict outcome for patients with meningiomas, and this work was published in Neuro-oncology in 2019, and since then, we've adopted this methodology in our clinical practice and use it on a regular basis in Toronto Western for decision-making for our patients. For the interest of time, I might stop here and see if you have any questions. If not, I will move to the second part of the talk.
Well, thank you very much for the first part. I do see a question already, Mohammed, and then Niku. So 2 questions.
Thank you very much, Dr. Gelareh Zadeh. This was amazing. So you mentioned about this algorithm that you can predict the recurrence, but is it possible actually to predict whether this tumor can occur in the first place as a risk factor? So can you actually use this algorithm to see that maybe 10 years down the line, 20 years down the line, someone will get a tumor?
Oh, I see. Yeah, that's a really good question. So part of the work that we've done, which I don't think I'll have time to show you today, is about 1.5 years ago, we published this work in Nature Medicine, where you can use circulating tumor DNA and look at the methylation to diagnose the tumor. And then also similarly, be able to subclassify it. So say whether it's a meningioma, a glioma, and then look to see if the grade is determined. So your question, I think, is, can you take my blood right now and use that circulating tumor DNA methodology, look at the methylation signature and say, there's something in your plasma that's outside of what your normal methylation signature should be, and this is a predictor for brain tumor occurrence. So that's certainly possible, and currently we use the CF-MEDIP to demonstrate that we can make the diagnosis. Our ongoing research is to show whether we can use the methylation in the circulating tumor DNA to predict outcome, as you've said, but can it be used as a diagnostic tool or as a screening tool? The answer is it certainly can. What it requires is large population-based studies, because in order to be able to accurately be able to say, I can determine that the blood test, much like PSA for prostate cancer, is going to tell you that you have that, will require large population-based studies. Brain tumors in general, luckily, are not very high in incidence. So in order to then be able to capture a population that would have possibly brain tumors and then follow them for a period, you would need many thousands of patients. And on other cancers where the incidence is higher, for example, for breast cancer, lung cancer, and other, they are doing these studies. The brain is always challenging because the numbers are so small. So in order to be able to make that study possible, you would need multiple more hundreds of thousands of patients to analyze. And then, of course, that becomes a question of where would the funding for this come from? And just executing on that. You would need a lab beyond just an individual PI's lab like myself dedicated to that to be able to answer a question like this. So the technology is there and certainly possible. It's a matter of whether you would be able to realistically, in fact, implement this. And I think at some point in the next 5 years, this will be done. but it would be outside of an individual lab. It would be some industry or pharma that would take this on and can do it at a large scale. And these are, the studies that they do for GWAS type studies, where it's genomics and epigenetic and epidemiology-based studies that people do based on large cohorts of samples that they have associated with clinical databases. So the ones where you follow somebody from birth till mid age, or probably later, in fact, that you could then be able to make those accurate diagnoses. Technically, it's possible for sure, but really a good question.
Okay, and I think Niku is next. You can go ahead.
Thank you. Hi, Dr. Zadeh. Thanks for your talk. My question is regarding the methylation signature for different tumor types. I'm wondering, I'm not sure for meningiomas what the standard of care is. Do they undergo radiation therapy or anything? But do you see any changes in methylation signature after therapy? So any therapy-induced recurrence or lack of recurrence because of the methylation change?
Yeah, so that's a very good question. We're actually doing those studies now. Radiation is the only other treatment option after surgery for meningiomas. There's no effective chemotherapy or targeted treatments, etc., unfortunately. But that's partly, again, a reflection of, as I said at the start of my talk, research in this area is quite limited. So one of the areas that we're looking at is to see, does radiation in fact alter methylation signatures? It doesn't appear to, because the epigenetic signal is quite stable. It's quite redundant. And so I think that's in part why. What we are seeing, not in meningiomas, but in other tumors, the glial tumors, that perhaps as you go up in grade, so you transform from a lower grade to a higher grade, you then see a change in methylation because you probably acquire additional genomic alterations that impact methylation. Whether it's related to treatment, because some lower grades are treated before they transition to higher grades, that's possible. But a very good question as well, again. Thank you.
Yeah, Irene, please go next.
Yeah, thank you. Hi, Dr. Zadeh. Thanks for a very interesting talk. Also had a similar question regarding the methylation signature and whether it changes over time, and specifically, is there or are there chemotherapies that can be tailored towards methylation signature? I know you mentioned chemotherapy isn't currently being used, but I'm also wondering, I guess, with that, what the current status is of targeted chemotherapy via opening the blood-brain barrier with focused ultrasound, and if that's been applied for meningiomas.
Yeah, so again, a really good question. Maybe the first part I will go first is that it's focused ultrasound. Well, it's actually not the first part, it's your second question. Focused ultrasound for meningiomas, as you might know, I think you work with Andres, right?
That's correct.
I recall, yeah. Majority of the meningiomas are in a very superficial location. And so to reach the levels we need for the high energy ablative would pose a risk. Now, from a biological perspective, and I think you're familiar with this study that we're doing to look at the circulating DNA pre and post focused ultrasound in gliomas. Certainly interesting to do that in meningiomas as well. It'll be a question of how do we then convincingly ask a patient to undergo high frequency ultrasound for a meningioma, because there isn't a proven therapeutic benefit to it. Unless you go with the low energy, high frequency ultrasound, where it is intended for breaking up the blood-brain barrier, and see whether in so doing, you're able to improve on the diagnostic capability of the circulating tumor DNA, because we've already shown without high frequency ultrasound, you can't accurately diagnose brain meningiomas. But maybe by opening the blood-brain barrier, you can use that methylation signature to be able to more accurately predict, and I think the first question was from Mohammed, is can you use that methylation signature to more accurately predict the outcome for the patient, just like we did with the predictor itself? In having answered the second part, I forgot the first part of your question. What was the first part of your question?
It was tied to Nico's in terms of does the methylation signature, I guess, change over time? I mean, previously you were mentioning after radiation or some other exposure, but
so in particular for meningiomas, what you would need to do that study, which we've tried, but the numbers are limited, is you need a patient who presents with a grade 1 meningioma and then transforms to a grade 2 or possibly a grade 3. And every institution has a number of those cases. However, they're not sufficient to be able to do the large scale studies. The studies that I've shown you each have a minimum of 200 cases in them. So that would be the challenge, is that, and the International Consortium on Meningiomas is designed with that intention so that you can maximize the number of cases you can gather from any one institution and then pool your results. So if you look at ours, the number of tumors that go from one grade 1 or 2 to a higher grade 2 or 3 is about 18. So it's good. It will give us a sense of whether there's a change in methylation as you progress to a higher grade, but you need more to be able to prove it definitively. In gliomas, like I said, we have a more generous number of matched primary to recurrent tumors, and you don't see a change in methylation when it's from one grade to the same grade. But if you increase the grade, it appears that that progression to a more malignant state, most likely due to acquisition of increased mutations or copy number burden, etc., you then see a difference in methylation. And I remember now what you asked is, are there treatments that you could target to take a unfavorable group of tumors to a favorable? And that's a fairly, I would say, hot topic area in not just neuro-oncology, but other areas of cancer. The challenge there is, and I didn't show you some data we published recently in Nature on meningiomas, though we found vorinostat, which changes methylation signatures, to be good for a subgroup of meningiomas, our MG4 group. The other subgroups actually don't benefit from it because they don't bear those methylation alterations that MG4 does. That's one. Two, altering methylation of a promoter changes the expression of that gene. Whether it's hypo or hypermethylated, it could turn off and on the gene expression. So then the ultimate question is, so you take it from a hypermethylated state to an unmethylated state, making it more favorable perhaps. But then are you actually, in the consequence of taking it to that unmethylated state, changing gene expression to now introduce a new issue with the tumor that makes it more aggressive? So it's not as straightforward or linear as it would appear, because by altering methylation, and there are a lot of epigenetic modifiers, and there's a lot of interest to pursue whether an epigenetic modifier could impact the outcome of the patient, you have to also then study, which is what we're doing in an ongoing manner now. Once you use vorinostat, what was the gene expression before and what is it after the treatment? Because you may, as a consequence, increase expression of a random gene I'm going to throw in there, VEGF, which is an angiogenic gene. And now you've made the tumor more angiogenic. And as a consequence, they're more aggressive, in fact, in that regards, compared to their previous version of what they used to be. So I think it's certainly interesting and requires more work, because if it was straightforward, we'd obviously have the answer already. So, but very good question.
Great, thanks for that.
Mm-hmm.
On that positive note, we have one more question, I think, from Rajesh.
Hi, ma'am. Thank you. That's a great talk. Really eye-opening for lots of things. So, ma'am, I have two questions. Do you think while you think that with this methylation study, the role of amount of resection after every surgery, amount of residual after a surgery also play a part? I mean, somehow is it also a correlating thing that we do see recurrence in those cases in which tumor has been left because the tumor was resectable, it was attached to the major vessels or major nerves over there. And if we are doing a complete resection, in that case, the recurrence is less. And
yes,
that study of methylation, I mean, are you understanding what I'm saying?
yeah, for sure.
Yeah.
If you remember, when we create the calculator, 100 score, the 100 weight, 100% of the weight of the calculator is based on the methylation score. But there are other factors that come into the predictor. One of them was the WHO classification, comes into effect by a weight of 50%. And then the extent of resection, which is what you're asking, came into a weight of approximately 25%. So the extent of resection does matter, but not at 100%. The value of methylation outrides the extent of resection. So methylation is at 100%. So if you set that at 100%, the relative contribution of extent of resection, how important that is to the outcome of the patient, or how much weight it has in predicting the outcome for that patient, sits at about 25% compared to methylation. So absolutely. And this calculator was created by plugging in all sorts of different factors that we use clinically that we know. So proliferation rate, those 18 different subtypes that I showed you. For interest of time, I didn't show you all of the calculations we did. And what came out to be significant in the multivariate analysis ultimately is extent of resection at 25%, the WHO grade at about 50%, but methylation definitely supersedes it, which is why it's at 100%. And then you combine that and come up with your 5-year survival rate.
Awesome.
You said you had a second question?
Yeah, I mean, ma'am, do you think that the way things are changing in molecular biology, I mean, the surgical role and the surgeon's role is going to change in next few years? The way, I mean, things are changing molecular level. Are we like going to be more oncologists rather than a surgeons in future?
I don't think so.
Sorry.
No, because I think in particular for diseases that impact the brain, the first goal is to remove the pressure and to remove the encasement of tumor around vessels and nerves, etc. So I think there's always going to be that need. Now, say we get to a place well after any of our lifetime where you can predict that I am about to develop a brain tumor. And so you can scan me on a frequent basis before I ever get to a tumor, which is to the size that it puts pressure on the brain. Then possibly you can move to more and more minimally invasive treatments. But I do think if we were realistic, it would be outside of our lifetime to get there. I could be wrong, but if you look at the patterns of what's come before, you can kind of predict the trajectory of where our knowledge takes us in general.
Awesome. Thank you. No,
yeah,
just intrigued. Thank you.
Okay, so I think, what is it? We have till 7?
We have until time.
Pardon me?
Until you have time, we have time. So
okay.
We're happy to do the second part.
Yeah, well, I also don't want to lose your interest, but another topic I thought perhaps would be of interest is to talk about mentorship, diversity, and culture in neurosurgery in particular. And as you're, I imagine, logged in on a Saturday evening, you have an interest to pursue a career in neurosurgery. And I just wanted to give you some of my own experience. I immigrated to Canada and went to medical school in Manitoba. I arrived just at the tail end of grade 12. So I finished my undergrad. I thought I was going to become a mathematician. And through a fairly fluke event, I didn't like one of my professors in my second year of actuarial mathematics degree that I was in. So I had to drop that course, which meant I couldn't finish that degree. And a couple of my friends from high school said, well, why don't you write the MCAT? And I thought, okay, I can try that. That's how I got into medicine. But then as I was going through medicine in Manitoba, I was exposed to neurosurgery, and I'll tell you how my interest was sparked. I finished neurosurgery, and I also did a Ph.D. in molecular biology. I completed a training in neuro-oncology, did some research on how to design clinical trials in radiation oncology. I worked in the UK for a short time and came back to Toronto Western. I really missed the rich environment of being able to build an academic career. And I started mainly as a skull-based surgeon working on pituitary and acoustics, as I showed you earlier, but also taking out all other brain tumors. 95% of my practice is currently focused on neuro-oncology. I'm one of the few skull-based surgeons in Canada. And I also then started research, continued my PhD research on angiogenesis, tumor microenvironment, and really then moved to genomics, which is part of what I showed you. So these are the tumors that I showed you earlier that we deal with in our practice and where my research focuses on. And the reason I moved into meningiomas was I saw a need, an area that was perhaps ripe for me to focus my research, given that there aren't that many other labs focused on meningioma research. I'm very proud. I have a lab that's very diverse, a great group of people. This is just right before the pandemic happened 2 years ago. I had a small baby. I also have a 14-year-old as well. And we were able to be unmasked and together, and it seems like a lifetime ago since the pandemic happened. So what does it take really to be an academic surgeon? Training typically involves either you do an MD PhD or an MD Master's, MD Fellowship in order to gain an academic focus and interest. The considerations are the length of time you have to put in for your studies, and it takes commitment. It takes commitment to focus on getting this training because it is typically 10 to 15 years after you finish medical school. The environment that you pursue this is really important. And I have to say that going to London, UK was a very good experience for me because I more acutely became aware of how the environment in which you work is important. You need people who are like-minded, that have a critical core mass of people that would want to contribute towards an academic department. And so coming back to Toronto Western really allowed me to do that. Identifying the right mentors, both on clinical and research, and at any stage of your career, you rely on new mentors. Some continue because they have that ability to. And then equally, I would say collaborators. One thing that I've learned that is important in the last 10 years of my career is the importance of building collaborators, strong people that you can trust and be able to delegate and also complement what they do as well. And critical to all this is time management. So how do you fit all of this in the hours of the day? And it's essential, and you then learn through the process of this training on how best to manage time. The advantages in general that I see is that you're put in a position where you are looking at things in a problem-solving manner. So all of the questions that you asked me in the last 10 minutes are reflective of that. You have a scientific curiosity, and you want to be able to solve the questions that you're asking. But problem solving isn't just restricted to research. It impacts the clinical management of your patients. You need to have that curiosity to be able to solve the problem for them, whether it's a social problem, a personal problem, or in fact, a clinical problem, which is typically majority of what we do as neurosurgeons focuses on solving the problem of, for example, a brain tumor that they come to. And then problem solving in your life and personal aspects of your life. Potentially you have interests politically, socially, etc. And then navigating the challenges of an academic surgeon career, I think requires, as again, reflective of what you're doing as a group, preparing for it very early on in your career, to be able to understand what it takes, what are the elements that come together. Having said that, I've really developed this knowledge and can look back and say that there were people in my life that allowed me to build that roadmap, but it wasn't one that was presented to you. And I don't think any one person can actually present you with a roadmap and say, follow it. And at the end of it, you're going to get to an X position. because each of you have very unique talents, very unique strengths, learn differently, respond to your environment very differently. And so it would be very unique to each individual person as to what that roadmap looks like. The most important is to encourage to take risks, recognizing that as a consequence of taking risks, there's a failure that comes with risk taking. So then the question is, do you really look at them as true failures or an opportunity that's created where you learn and build on that failure? So I typically don't view when I take a risk that if it doesn't work, that it's a failure, but rather it just didn't work the way I expected it. However, that opportunity provided me with something that I can build on. It is really important to collaborate, and that's something that takes a while for it to actually mature. And whether it's collaborating on projects and courses that you take, or during residency, in an area that we're almost made to or forced to by necessity collaborate, is taking care of the patient. Because the good of the patient is at the ultimate center, and two or more physicians have to come to an agreement to be able to deliver the best care for the patient. When I'm in the OR, I have to collaborate, and the trainee has to collaborate with me so that together we can operate on a patient, trust each other, and come out of the operation doing the best for the patient. So it's really important to know how to build that trusting relationship for collaboration. And equally then, value that it's not just yourself that's making an advance, although we're judged based on our own merits and our own accomplishments. Contributing to a team is very important and essential. And as I said before, you accept if there's a failure, and you're relentless because you have a desire to get to the next stage, and you would know and trust yourself that you're going to be able to overcome that failure, or perhaps find a way around it in a different direction. Some of the points that are very unique to being a surgeon scientist is that surgery on a patient is a very personal task. And so the connection you make with the patient is quite unique. This is not to minimize the connection that patients who are internists or other physicians is in any way less than what we go through. But for a patient to trust that they would allow you to take them through an operation, for some of the work that we do, the outcomes are such high stakes that in order for the patient to trust you, you then have to really be present for them for the entire duration of that clinical care. And there is a burden that comes with that, but not burden in a negative way, but that you are responsible from the point of contact and introduction to the point of completion of care. That's very unique for surgeons. And that's something that you need to enjoy and be able to actually accept it. And you're not replaceable. So if there's an operation that I do, though I collaborate and other trainees, residents, fellows can work with me, ultimately the responsibility and direction of the operation falls with me. Now, sometimes I delegate it. If a resident is very strong, I'm comfortable that they would be able to take on that responsibility. But ultimately, it's me as the individual surgeon that has that responsibility. This is different from other fields of medicine because there's an opportunity to cross-cover each other in other areas. And some of the operations that we do, in particular what I do for skull base, they're very unique. They're not reproducible by anybody else in my group. So, and the reason they're unique is really because there's not that many times that we need to do those cases. And so you become extremely subspecialized. The other issue is that as you embark on becoming a surgeon and a scientist, or whether it's a scientist or another academic interest that you have, whether it's teaching, clinical investigation, etc., you would still be designated as a surgeon scientist. The amount of time that you take away from surgery to build the other elements of your academic portfolio puts you at risk of perhaps using that finesse. And so this is why time management becomes really essential compared to, again, other subspecialists where their main delivery of care is through their knowledge and what they've acquired, and their ability and skill sets is cerebral. So if you don't really work 2 or 3 months and focus on your research, it's not as big an impact as if you don't operate for 2 or 3 months. And then when you come back, you've lost your finesse. Most importantly, during your training, the concern that we're always faced or asked about is our model at University of Toronto is very unique. We encourage residents to take time off when they're 4th year to do research, but extend that 1 year research to a minimum of 3 or 4 years of, to go to research and take 3 or 4 years to do research. The concern that's always raised, well, if I go away for this long, am I going to de-skill? Certainly the refinement of the skills need to be brought back up to standards when you return from research. But in fact, we find that because of our volumes and the method that we've developed, our residency program, and the tradition is so strong that when you come back, the skill sets return back to their baseline and you're able to skill back up during your residency training. So the challenges are, again, time management, because you're trying to really build 2 elements to your career. You then have a personal life that you like to develop and focus on and find a balance between everything. And so identifying methods in which you can protect your time, which is through, as I said, building trust and collaboration, being able to delegate, and being able to find ways where the team around you is directed towards the same goals and same mission. It's challenging in that some people, if you like a very regular schedule, there's unpredictability in your schedule. So at any one time, you may be called to go to the OR. You may have experiments planned. You may have a lab meeting in my case where I'm asked to go to the OR. Or if we're in the OR, sometimes there's a deadline for a paper that I need to meet. So you have to be able to ultimately manage that degree of unpredictability. The most important step really here is to identify mentors that along the course of your training can help see perspectives that are outside of your own. They've lived through similar experiences and can support you. And so why do I do this? It's because I find the academic environment stimulating and dynamic, and it keeps me up to date. And so I think the layer of academia that comes with the work that I do that I showed you previously continues to stimulate me. And I like the problem solving element of it. And another piece of it, which I think you don't find in literature, I really enjoy my interaction with the residents. The residents always get younger because I can't believe I'm getting older. So it's always interesting for me to interact with them. The younger generation always have new perspectives. They have new talent and skill sets that I don't. And so that to me is an amazing part of my day-to-day activity and work. And then we have unique perspectives as clinician scientists. We know what the actual impactful clinical question is. So the work that I showed you, there's a reason I showed that, because the research that I've done is an immediate impact on how we manage patients. And the publication from 2019 to now 2022, we've already changed how we manage our patients with meningiomas in our clinical practice. So that to me is impactful. It's extremely rewarding, and it demonstrates that we understand where the need is to focus on research. And as I mentioned, the younger generations in the intellectual capacity that they bring, and also the ability to interact on a day-to-day basis with a wide range of scientists that are not really from my world of neurosurgery, but they're from the world of basic scientists. So when I mentioned the publication on CF-MEDIP, the circulating tumor DNA in the plasma, that's a world that if I had been a surgeon, I would have not necessarily perhaps ventured into. But because I'm in an institution where there's an extremely strong scientist and I can collaborate with them in a genuine manner, that's really quite rewarding. And the collaboration and partnerships are what allow me to, in fact, grow stronger as a clinician scientist. So just a few words about women in neurosurgery, and by it being few, it doesn't diminish the value and importance of it. If you look at the data, it shows that less than 10% still of the practicing neurosurgeons are women. It's one of the only surgical subspecialties where percentage of women continues to lag behind. Of the 6%, and these are American data, but applicable to Canada still, about 5% are in private practice of the 6%. So very few are in academic practice. 10% of neurosurgery residents are females. 0.2% of medical schools graduate apply to neurosurgery. So I've seen a number of you are females on the call, and so it's interesting that such a small percentage are still showing interest. The American Board of Neurological Surgeons, 3% have that certification. It's a two-step certification. Step 1 is after you finish your training. Step 2 is the optional choice, is when you get into clinical practice. So this number being 3% reflects that after the female neurosurgeons graduate, 2 years into practice, you have to apply for step 2. But there's social perhaps factors, work pressures, family pressures that prevent them to write the second part of the ABNS. And so only 3% have full ABNS qualification. At the time the study was done and I prepared these slides, only 3 chairs of neurosurgery were female. In North America, the number now sits at 6, myself included. 30% of the US residency have never graduated a female neurosurgeon, and 6% of all female neurosurgeons are at the professor level. Less than 1% of female neurosurgeons are surgeon-scientists. American Academy of Neurological Surgeons is one of the well-recognized institutions or organizations of neurosurgery. Until 2007, there were no female members. And until 2010, the main 2 societies of neurosurgery, the Congress of Neurological Surgeons and the American Association of Neurological Surgeons, had no female officers. They are making an active effort to increase this number. And so in the last 5 years, 2 of the presidents of American Association of Neurological Surgeons are females. The past one was the current chair in Indianapolis, and the incoming is a lady, Dr. Stroink, Anne Stroink, who will be the president of AANS. So the reason I put these statistics up is that the data is real. The reason there is not a huge increase in the numbers and the percentages is that there are strong factors that continue to challenge all of the divisions, all universities, and being able to appropriately support and sponsor females and attract them to go into this field. Some of them, I think, are well recognized. Some are that are not very well recognized, and there's a need to move to understand those areas. A majority of people, when they're surveyed, in fact, females and males, on why this is a persistent issue in neurosurgery, report that there's 80% lack of mentors, or more importantly, role models. So although the perception is that perhaps there are stereotypes associated with what a female needs to do for their social life and also their work-life balance, the lack of a role model is the cited number 1 factor that results in people not going into neurosurgery. And if you recall earlier on in my talk, I said, creating that roadmap for you is very individualized. And so generally you create roadmaps because you identify with somebody and say, I'd want to do this because Dr. X did it this way, or my experience with this was resonating with the person I interacted with, and you find a kinship and a alliance with that person, or there's a parallel to how you view and they view their careers and their personal lives. When there's less women in the field, it becomes then difficult to identify how or to establish that roadmap for yourself. And so that's one of the main factors that influences the decision. And there is a perceived sense of the glass ceiling, which I think this is something that at later stages in the career perhaps is more of an issue. Now, if you look at my own trajectory, if you look back to when I became interested in neurosurgery, I really didn't actually know neurosurgery was a distinct subspecialty from neurology. You might be surprised to hear that. When I was on my early elective in Winnipeg, I did a neurology elective, and the ward was shared by these 3 neurosurgeons, Norm Hill, Michael West, and Derek Fewer. And they saw me on the ward one early morning and they said, you know, who are you? What are you doing here? I said, I'm doing an early elective in neurology. And Michael West said, oh, you don't want to do neurology, you want to do neurosurgery. Come to the OR with me. So the next day I went to the OR with Michael West, and that was it. I was amazed by the anatomy of the case he was doing. He was doing an arteriovenous malformation. He is an extremely great teacher, a wonderful person, great with the patients. I just really liked everything that he stood for. And so I resonated, his style resonated with me. And I did think that I would like to grow up and be like this person. Norm Hill was a very different person, but he was quite visionary. And he said that we need more women in this field. And he was very supportive of me at doing this. And Derek Fior was just a lovely teacher. So in fact, people who made me interested in neurosurgery were these three gentlemen. When I then got into neurosurgery and wanted to do my Ph.D. and then did my clinician-scientist training, the three people who became my notable mentors are Ab Guha, who unfortunately passed away 10 years ago from leukemia, Jim Rutka, and Dick Hill. Dick Hill unfortunately passed away this year from leukemia, well, multiple myeloma, but outstanding mentors for me that helped me build that roadmap for myself and recognize that I had this ambition and desire to become a clinician scientist and guided me in so doing. The people who provided me clinical mentorship as I went through my residency were Mark Bernstein, one of my partners who retired just this year. I had the honor of becoming his head of division. Fred Gentili, who's my partner and unfortunately quite sick with glioblastoma himself. And Chris Wallace, who was our program director. Again, three gentlemen who really shaped my training and shaped the way I practice and wanted to build and model myself after Fred Gentili as a skull-based surgeon and Chris Wallace as a teacher. And you could see other names that are on this slide. And notably, I would say that although I value all and each one of them for everything that they've done for my training, for my early career, for partnership in the OR with my head and neck ENT surgeons, for research, for the leadership roles that I've taken, you could see that all of them are men. And it's because there were no females that I could actually select from. Not because I didn't want to, but in fact, I never have had, for example, a senior female surgeon that I've worked with. And I have Dr. Hodai, you mentioned that she spoke at your event about a year ago. Her and I are similar vintage, and she's a great partner. Her office is just next door to me, and her and I are peers, and it's been fantastic for me to have a partner. She happens to also be Iranian. So we have a wonderful partnership, collaboration at work. And personally, it's great to have her. But outside of her, I've never had the opportunity to have a woman generate the roadmap. So what I now see looking back is that each one of them helped for me build my roadmap. And sometimes you have to be a little bit creative in how you envision your own life. But hopefully moving forward, we can have more females that act as role models, not just for females, but for men as well. And I would say the group that now really helps shape what I do academically are our trainees, our residents, and our fellows. As I said earlier, they're the younger generation with the most dynamic, up-to-date, advanced knowledge and information who help shape the directions that we take as an individual, myself, as a lab, and then ultimately as a division. I think I've gone well past the hour. I'm going to stop here. I have more slides to show, but I want to give you some time also if you want to have dialogue around this. And also, again, thank you very much for the opportunity.
Thank you very much, Dr. Zadeh, for this wonderful talk. I'm sure everyone is grateful and very humbled by this. I have one question to ask, and then if that's okay, and then we'll
of course.
do Q&A. So you mentioned your interaction with Dr. Mike West and how in your third year, your whole trajectory in life sort of changed in a very intuitive way. Would you say if you had continued pursuing mathematics, something more abstract, would you have been equally fulfilled in alternative life?
I don't know. It's a good question. You know, I always think I could have been an actuarial mathematician. I would have worked in a big bank in London, England. I would have lived the high life. I think so. Yeah. Yeah, I don't know. You know, I think fulfillment is relative in what you make of it, right? In general, I think life is about perspective. We could both go through the same experience. I enjoy it dramatically, and you think it was okay, you know, it wasn't that great. You watch a movie and some person likes it and the other person thinks it was a bit boring. It's all about perspective and what you make of it. I think in general, ultimately, what you do, where you do it, though are important factors that help build your career path and who you are as a person. It's what you make of your circumstances, you know. And it depends on your perspectives at a certain age, at a certain period in your life. So it's hard to know. I mean, unless I go back and do that, it's impossible for me to answer the question. But I think I would have probably worked in a bank and been one of these amazingly successful bankers. Well, I wouldn't have been amazingly successful, but I would have been a relatively successful banker and enjoyed a very comfortable life in, as I said, London, England, which is the city I love to live in. But it was tough practicing medicine in the NHS system for me, not for people who are from there, but just obviously for me.
Wonderful. Thank you very much. I'll pass it on to Pedram to continue the Q&A.
Oh yeah, sure. I think Heather has a question. Heather, go ahead.
Yeah, awesome. Thank you. And thank you, Dr. Zadeh, for the very inspiring talk today.
My pleasure.
Fourth-year medical student at the University of Manitoba, so it is awesome to see some Winnipeg and Manitoba representation.
Are you from Winnipeg?
Yeah, born and raised here.
Okay. Where did you go to high school? Here's my chance to reminisce.
So I grew up actually in East St. Paul, so just outside of Winnipeg.
Right, okay.
Went to high school at MBCI.
Okay.
Yeah.
Sorry, go ahead.
No, that's okay. My question was more around your leadership roles. So as someone who's taken on many leadership roles throughout your career, I was wondering if you had any formal leadership training throughout your medical education, or was this kind of something you learned on the fly as you took on those roles? And then kind of to add on to that question, do you have any advice for someone who would want to pursue leadership within the field of neurosurgery?
Yeah, really good question. So my leadership role started really, I would say, with an opportunity that came about by the Surgeon-in-Chief, Shaf Kashabji here at UHN, encouraging me to apply to become the head of Division of Surgical Oncology. I always thought when you're a head of something, it's a very administrative job. There's a lot of politics, really not for me. I'm more an academic phenotype. So although I inquired about it, I never applied. And he called me after the deadline and said, why haven't you applied? So I applied at his encouragement and I was given the position. And I realized that actually I was wrong about being in a leadership role, because the leadership role allows an opportunity for me to change that perhaps negative perspective from a clinician, academic clinician's perspective of it's administrative, there's a lot of politics, it's a cumbersome task, etc. And it's not impactful or effective, because you then develop an opportunity to introduce a new style of partnership with all your division members. It gives you the opportunity to control your environment a little bit better and make processes easier for yourself and your colleagues so that you can do what you like to do. And then also implement changes that would be noteworthy and hopefully ultimately long-lasting. So that first experience allowed me to build on the leadership roles that I took, with currently, I would say, the culminating in taking on the role of Dan Chair. Did I take any formal courses? I didn't. I did take a Rotman course. Maybe I shouldn't say the name if you're taping me. It didn't resonate with me, but I wasn't really ever a big classroom-based learner. In medical school in Manitoba, I think the dean's no longer there, so you could repeat this. I may have gone to maybe 20 hours of lectures or something. People would ask me for my notes and I'd have like a single page. I prefer to sit. I'm more self-directed learner, I think. I prefer to sit and read than to go to the lecture. Some people do really well with lectures. I'm not poo-pooing that. In fact, that I think it's just each person has a different style. Leadership, I think a lot of leadership is understanding people, in fact, and having an interest to genuinely understand them. I didn't get to all my slides, but my style isn't that I lead because I dictate people to do what they want to do. It's more, how do I bring a group to a consensus, as near a consensus you can get on an issue and a topic, and then execute on it, because I have the ability and the connections to the people to determine how to make those executions, or how to enact a project or an idea that we all come to some sort of an agreement to go to the next phase of it.
Okay, Niku, you are the next.
Thank you. Dr. Zadeh, I was thinking about kind of like you mentioning your journey and also touching on social factors that affect women's decision as to whether they should go into neurosurgery or not. Based on your journey and also like other people that you see in the field, your trainees, your colleagues that are women, do you think there are certain time points in someone's journey, let's say, different ages or different life milestones, that do present that challenge of like deciding or are kind of like the decision-making times in someone's life? And are there any interventions for those times to kind of push women to feel more comfortable going into neurosurgery?
Yeah, I think I understand your question. I think one of the issues is, because the training is so long, that you can't really defer it. I mean, if you defer it by 10 years, by the time you graduate, you're past your middle ages. And so that is probably one of the bigger challenges. The other challenge, which people are now more open to speak about, and it's not just neurosurgery, it's other surgical fields, is the simple fact of biology. So modern medicine allows us to overcome biological limitations, is that your most fertile age is during your residency. And there's clear data that you're at higher risk of infertility as you're a senior or even a junior resident, because you're running around half the time, not eating, resting, sleeping, etc. So the rate of infertility during the residency period is quite high. And once you're done your residency, you then start getting to a period where fertility becomes an issue for women, because you're now considered an older age, though you're not aged. But modern medicine luckily allows you to overcome many factors. So if you have cardiac disease, you get your heart stent and you live longer. If you have joint disease, you get your joints replaced and you can walk better. If you're a female and you have to delay your fertility, you can have your eggs stored. So, but that's a little bit of a taboo. And I think, if you go to a lecture where the speaker is telling you to do that, you might think, what? I didn't invite her for this conversation. But that's the reality. And it may seem foreign to people, but it's no different from, of course, there's modernization of what we do in the world in general. There's airplanes, and if I had to rely on flying to London, without a plane, I'd never get there. So it's the same thing. I think there's ways around the factors of the fertility. That's the mechanics of it. The issue is that probably the bigger factor is how to shift the culture to say, I accept that. And I think the shift has to come not just from women, because we would accept it. It's actually others who have preconceived ideas of what every person's role is. And this isn't actually a statement about women only. In order to accept diversity is that you have to have no biases, so that you are accepting of people as long as you're not hurting the rest of the population or the community. Your choices, your actions are considerate of others or neutral, and so are not negatively impacting others. You could really choose to do whatever you want. And that's where ultimately you really reach diversity. But that's a bit of a utopia, because we're all born and raised to some extent by certain biases, whether it's by culture, by societal norms, by expectations. It's a matter of how do you get yourself beyond that. And some people don't want to, because they like the certain directions that their culture, their upbringing directs them to. But then that becomes challenge as to how you resolve these two, in that if you do expect to have a big family early on, you may have to delay your training a little bit. The challenge then in neurosurgery becomes it's a fairly long road. Now, maybe the next phase of this is to say, okay, well, you start neurosurgery training in your late 40s if you wanted to have a big family up front, but then you're not perhaps contributing as much to the workforce. But maybe that's okay. That shouldn't be considered a negative. Does that answer your question? Did I understand what you said?
It does, yeah. I feel like at the end of the day, it comes down to like a trade-off. And it sucks to say that like you have to choose between things at the end of the day, but yeah.
Yeah, I think everything in life is a choice, right? Yeah. There's always a choice.
Opportunity cost.
Yeah, it's from the moment you wake up, you make a decision. You do X versus Y, right? I brush my teeth or I don't. I'm going to brush my teeth. You know, there's small scale and then there's large decisions, but I don't know that they're a trade-off. I think it's just the reality of how things go sometimes, right? It's a choice. And I think you then say, can I find a way around it to have both things? And sometimes, yes, the two choices that you're deciding between, it's not possible to have both of them. You know, is it possible? When I started my residency, I thought I'm going to have 5 kids. It's not possible. It's not possible for me to have done all of this and have had the 5 kids back when I started. Is it possible to do it now? I think it's possible because there's certain biases that have been eliminated. And I think some of that has been catalyzed by the movement of recognizing EDI, the equity, diversity, being inclusive. And so the time I trained, it wasn't possible to have a child be pregnant and do your training because they would tell you to take time off during your training. That meant if I wanted to have 5 kids and the residency is 10 years, I'd never finish, right? If you do the arithmetic. So, but that perspective's changed, luckily, due to the movement. Now, a lot of this focuses on childbearing, but there's other things people like to do. You know, for example, there's a piano in someone's background. Maybe he wants to also be a concert pianist. Could you be a concert pianist and be a neurosurgeon? Is it possible? In fact, last year in our candidate pool, there were a number of extremely talented, accomplished musicians. The reality is to do neurosurgery, it requires X number of hours of commitment to be able to do it well. To be a musician, a concert musician, equally requires that. That choice is not possible. Now, I could be proven wrong, and one of the candidates from last year will show me in 10 years that they remain a concert violinist and an expert neurosurgeon. But that actually, I think, is the number of hours that both specialties demand. And the reality is, in order to do neurosurgery well, it's a demanding number of hours you have to put to become proficient at a skill set that's quite delicate.
Thanks so much.
Mm-hmm.
Sorry, I do have a second question, but I'm not sure if I can ask, or maybe Mary can go ahead. It's brief, so whatever you prefer, Dr. Zadeh.
Totally, you're the boss.
Oh, not sure about that, but thank you. So on the binary note that he talked about, so just logistically, because being a certain scientist, you need to take protected time off, right? I mean, you need time to dedicate to surgeries and also running a lab. So how do you logistically do it? So do you take a week and then break it in half? Do you oscillate between weeks, or is everything merged in between?
Yeah, I think every person will land on a different model, and in each stage of your career, it's a different approach. So in your residency, you do, like I said, the time off, you take a sabbatical out of training clinically, and you do research. In your early career, you have to find an environment that allows you to take time off when you need to work on a grant, for example. So things such as salary support, startup packages, you need people that can help you with that. I tended to take specific days in the week that are only research and try to protect it as much as I can. But, you know, if there's an urgent surgery that's come up, I have to go to it. In a system where you're in a group that have a similar phenotype and interest, you can ask people to cover you. But now I almost do it in episodes. So I work a lot clinically, and then I go into research academic mode quite a bit. Of course, with COVID, everything's upside down. So, but I think at each stage of your training and then subsequently career, the model varies a little bit. But having people that can have your back and protect you, in particular with regards to clinical coverage, because there's that unpredictability, it's helpful. And then having the team. Yep.
Thank you. Mary's next, I think.
Yeah, Mary, go ahead.
Thank you so much, Dr. Zadeh. I'm Mary. I'm a fourth year at Queen's currently. And so all of our staff here are Toronto trained.
That's right. Yeah.
And I think something that, you know, when you talked about how when you look back on your past and the mentors that you had, them all being male have like really resonated with me, just because when I look back on my own, like me choosing to pursue neurosurgery in the first place, like all of my mentors and people that really inspired me have been like Dr. Wallace, for example, Dr. Jeff Wilson, and they've been males who have been so encouraging and so supportive of me having this interest. But then like now, my first time being in the OR, Dr. like Teresa Persner, it was like this like energy and this like motivation that I didn't even realize I had been missing or wanted until I was actually.
She's a very energetic person, though. Overall, I'm just gonna plug my laptop in.
She's phenomenal, and I think now it's like, well, part of me is also like, I think you had mentioned like, part of me is so interested now in neuro-oncology, whereas I used to be very much like Jeff Wilson. Like I was like set on spine.
Right,
and like I'm like, well, do I just want to be Teresa Persner, or am I genuinely interested in this? Anyways. I was just wondering, in terms of, you know, there's all these studies and research that goes into, that's looked at being female and minority within like surgical specialties, and how, you know, women in general tend to, you know, not ask for promotions or apply for promotions until they feel like they over meet the criteria, whereas males tend to, you know, they'll apply for as a reach. And something else that I struggle with is, now that there's more conversation on EDI, this aspect of tokenization, almost, of like not wanting to, you know, it's phenomenal that we're talking about these things and really trying to like, when you're making hiring practices and decisions, thinking about like the diversity aspect and being inclusive. But then I think on the flip side, now that I'm hearing there's, you know, people that are negative about it, saying, well, so-and-so was only hired into this position because they're a woman, because they're a minority. And I was wondering if you have any thoughts in terms of how you approach those situations or balance that, or, you know.
Yeah, I mean, it's a good question. I don't know that there is an answer that I can give you in a couple of minutes, because it's quite complex, right? It's an entire, I would say, field. Comments that are made about people getting positions because of perhaps affirmative action or strategic promotion of EDI are always going to be made, and it's made by those who contribute to this concept that maybe certain subtype of people are more deserving than others, regardless of their merit. It's a matter of, I think, in general, again, perspective. How much of that do you take to heart? So have there been people who said, I became chair of neurosurgery because I'm a female? Yeah, absolutely. But, you know, I think they're completely wrong, and it's their limitation in how they view the world, because I have the merit. And I would say I'm very competitive. This was not the only place that I interviewed for example. So I think it's a matter, again, ultimately, as I said earlier, what perspective you want to pick and how much you would then allow yourself to be influenced by things that are really simply negative. And that's where choosing the appropriate peers, mentors, and who you interact with. And I think it's true of even outside of medicine, correct? You don't want to be with somebody who makes you feel bad, is a very good principle. It's very simple. If somebody's making you feel bad, there's a reason. Either they have an insecurity, they have a personality problem, or you guys don't jive together because you have different priorities or different perspectives in the world. So people do say that. Now, having said that, I do not think that that should be permitted, and it requires people of wide background and diverse range to be given opportunities and promoted and supported to be successful, to demonstrate that they can do the task, so that comments such as this and cultures such as this melt away. And unless you're deliberate and specific in a strategic way to make that change happen, the idea that this will change over time is not going to be fast enough. So I think there has to be strategies in every division, department, university, where they promote diversity. And it's diversity of gender, diversity of perspective, diversity of preferences in life, and recognizing that each of us will be very individual and unique in how we see the world. And there's strength in that. And coming together would allow us to build stronger and build better. I do think that requires the leaders to make that sort of move and statement and to be deliberate about it, and the reason and intentional. Otherwise, it won't change over time. And you need to have processes and policies in place so that that movement does happen. And I think our social media has allowed us to actually gain that sort of a strength, because if you look at the time that I trained, if an issue happened, it was just my word against all of the people who are in the same category, in the same club, in the same mindset. So it would be me who was the outlier. Whereas now with social media, I recognize that it's just not myself that has that perspective. There's others that are like-minded and have gone through a similar lived experience. And so we can't all be equally crazy or all equally whining about something, etc. And I think that's really how we've become a bit more faster, or a bit more rapid in how we've reached to the point we are today. Because even 10 years ago, we weren't where we are today. And something really changed and catalyzed. And though there were a lot of negatives associated with the Me Too movement, I think it allowed you, for example, Black Lives Matter is a perfect example. If you didn't have the video to see that there was a deliberate action to kill another human being, you probably, if you read it in the news, would have said, well, there must have been certain circumstances. There would always be that naysayer that, oh, well, she got the position because she was a woman, etc. Same idea, right? Whereas now you actually see that, no, it was a deliberate, brutal act where Floyd died because somebody just twisted their neck inappropriately. They happened to be called the police person. And that's why the Black Lives Matter movement happens, because you do have access to that sort of data where we wouldn't have had 10 years ago.
Okay, thank you. I think we are past like almost 100 minutes of the event. Yeah, I know you're so busy. If you don't mind, I can ask the three persons have raised hand to ask the question altogether.
And then I do have to get home.
Exactly, sure. Thank you so much. So please go ahead and ask your question, and then I'm pretty sure Dr. Zadeh can answer the questions.
Can I ask a question?
Yeah,
so we're going to combine the questions, right? So all three of you could ask, and then Dr. Zadeh could give like an abstract summary.
Oh, yeah, okay. So what's your question, Ragesh?
Yeah, so ma'am, I'm coming from India. I'm 41 years old, and I joined as a fellow in pediatric neurosurgery in Children's Hospital, Ontario. My problems are a little different. Right now, the students are over here, bigger medical students. Two questions I would like to ask you. Ma'am, I was actually working over there because India has a large population. We have 1.3 billion, so I got a lot of chance to operate over there. But somehow I was feeling that somehow my training is missing, because some of the cases I was not able to do properly, or because I was feeling that there is something in North America, because they are writing all the literature which we are following over here in India. Something is there they are doing differently. So I joined over here, and my wife also came over here. She's the fellow in radiology with a 6-year-old girl. We came over here. So ma'am, regarding the questions about the women do not get so much chances over, because Canada, I would say, is a fair world where everybody is given a chance. Like myself also, I've been given a chance over here too. I'm developing my skills. My question is that how somebody, actually I'm more interested in the skull base, and it's very difficult for me actually to connect with the people over here for the chances of learning. So how do you think somebody, or what kind of skills somebody should develop at my stage? I was working as a staff in India. so that I can tell them, though, I also want to learn. People like IMGs, or like I would say people coming from other world, they are really having very difficult time actually in accommodating themselves and telling people that, okay, give us a chance to learn from you. I got a chance in pediatric neurosurgery, but like skull base, your word, your place, you're doing a great job. This is my question. And do you think that 41 years is a really old age to actually follow my dream of learning? Should I stop here, go back to my country and start practicing over there? I mean, it might sound a little bit awkward, this question in this discussion, but just I wanted to ask you. Sorry.
Yeah, no, I don't think your question is awkward. I think 40 is not quote unquote old. I don't think, when I use the metric of age, it wasn't so much an issue of being old. It's more of how far can your career go if you start very late. But 40 is not in that category. I mean, you're a fellow. It is challenging. I will agree with you in that there's only so many fixed fellowship spots in a country like Canada, where we have a limited number of institutions that offer neurosurgery. So, sometimes some of our fellows apply a number of years in a row, but we only would then have, if you look across Canada, there's really only about 5 places that would offer a skull-based fellowship. And typically every year, just to give you a sense, we get about 50 to 80 applications for the 4 spots that we have. Well, now we have 3. So I agree with you, there's a challenge. And unfortunately, there's a bit of a competition as to how people get to where they are. On a practical level, sometimes just doing an observership at the place you want to do a fellowship distinguishes you from the pool of the applicants, so that people can put a face to a name, see your level of interest and the strength of where you're at, and that would help. But that's really just more of a practical, not so much of a philosophical. But it is competitive. I mean, that's why in general getting into neurosurgery is competitive, and then the fellowships even more so. Maybe Natasha and then Ayesha.
Sure, I'll be quick. I just wanted to say hi also from Manitoba. I'm a first-year medical student at the U of M. And you kind of touched on it after I had put my hand up, but as much as there are huge movements right now about EDI, there is also a culture that persists a lot longer. And I was wondering if you could speak a bit about, I guess, what still needs work in that area, and if you have any ideas or like advice moving forward.
Yeah, I agree with you. I mean, I think things are moving faster than they were 10 years ago, but that doesn't mean they're absolutely at the ideal of where they should be. I think sometimes it's because you're anticipating and waiting or expecting that the change is going to be catalyzed by the minority group. But in fact, allyship and catalyzing change by those who are the dominant group is what's needed. And my personal opinion is that the efforts haven't been focused on the dominant group, because when you're a dominant group, why would you want to change? Everything's going well for you. You were the favored group, whatever category of diversity you want to pick yourself to be. You're the expected. And so it's really the responsibility of the dominant group to say, no, we need a change. I'll give you a perfect example. Every skull-based meeting I go, 99% of the room are men in black suits that show up very formal and show their cases, do their presentations. I, as the minority 1%, can't make that change happen. I can articulate it, wish it, desire it, but I need allies within that dominant pool that say, actually, why is our room filled only with men? Why can't I get other people to come into the pool and really diversify us? I mean, even biologically, when you think about it, why is it the same type of people that are in the same sort of context? So that would be my short answer. How do you then get the dominant people to change? I think, again, it's similar to what I said earlier. You need policies and processes. I mean, an extreme example perhaps might be some of the Scandinavian countries are enforcing, and there's pros and cons to that, but they're enforcing that parental leave of a year be equally shared by male and female, so that it's not a choice that the dad can go to work and the female stays at home for the year. A year is advanced, to take time off, but they're enforcing that both men and women have to take the same amount of time off. So the impact to their career is the same. It's felt really. And once you start experiencing, you realize better what you're talking about. Because unless you experience the biases, you may not actually understand it fully. Not may, you really don't understand it fully. So that would be my general answer. But again, it's a question that's bigger than the session itself. But certainly I think the minority do what they can to create the recognition that there's biases. The change has to come from the dominant body.
That makes sense. Thank you.
Ayesha? Yeah, my pleasure.
Good evening, Dr. Zadeh. My question is that, so in a field, like in the field of academia and becoming a clinician scientist, on one of your slides, you talked about being relentless, accepting failure, and then moving on. And so my question is more focused on sometimes the surgeon scientist or just a person early in their career in research is able to accept failure as a person, but the field of neurosurgery is very competitive. And so a failure like that, like a bad score on the transcript or not getting funding or a gap year or something, how can we make other people like the seniors and the mentors see us beyond that failure, that we're still putting in an effort and we want to make a comeback after a failure?
Yeah, I mean, again, a really important and good question. There are certain limitations. When you say you're relentless, let me give you, for example, if at this stage I wanted to be a concert pianist, it would not be possible, right? Because A, I don't have the musical talent to do it, and B, I don't have the number of hours. So if I say I should be relentless, even if I was relentless, I wouldn't get there. Now, if the entry into a certain area requires percentages to be met and metrics to be met, you have to pass your MCAT, for example, to get into medical school. You need certain marks to get into university, etc. Those are things that you could be relentless and it gets you past some of those barriers. But then there are some hard facts, which then you think, well, what would relentless mean in that scenario? And it could be that at the first try, you might not get into that particular field, but your way around it would be that you build a profile and a portfolio that makes you more attractive to a particular field. And I don't know what stage of your career you're at, but I think that sort of question doesn't have a broad answer. It really depends on that individual profile, because being relentless is fairly broad, right? It's more of again, a perspective or a personality and an approach to life. But the specific question you're asking, I think, requires a more individualized approach to your particular situation, because each one of you are going to have areas where you're going to be strong and areas that perhaps don't meet the metrics that are needed to get into a certain thing. Sometimes it's not actually you. You may apply for something and there's limited number and limited space. It's just reality. So you think of a way around it. So if you want to get into a certain specialty at this stage of your career and it's not possible, can you find a way around it and do something that then subsequently allows you to get into there? So for example, maybe you do a PhD, you become a stronger candidate, and then you apply back to medical school or you apply back into neurosurgery. I'm just, like I said, I have no awareness of what stage you're at, but those are some specific. I think your question is very specific, and it would require somebody that you trust to be your mentor to sit down and go through your CV with you and et cetera, and say, well, these are the things I would suggest that you do. It's not so much that it's a model fit all. And I don't think the point of the relentless piece was that. It's what you're demonstrating already, which is you come to a session and say, well, how could I get around this? How can I find a way to get around it? The answer depends a lot on the specifics of your portfolio. Did I answer your question?
Yes, thank you so much.
Mm-hmm.
All right. Well, Professor Zadeh, thank you very much for your wonderful presentations and making time for joining us on this Saturday evening. I think it's definitely fair to assume that all of us thoroughly enjoyed listening to and learning from your insights. We very much hope to see you again and host you again in the near future with our group. And we also like to thank all of our audience for joining us tonight. We are grateful for the great turnout and all of your interesting questions. I'm just going to quickly pass the stage to Mohammed to briefly talk about our upcoming events.
Yeah, thank you, everyone. Thank you, especially thank you, Dr. Gelareh Zadeh, for this amazing talk on the weekend. So
yeah,
thank you. I'm just going to quickly go over the future events we have at CaMSIGN. So the first event we have would be on 27th of January. We have the next UBC case of the month that we're going to discuss few cases of neuro-oncology. As you know, this event is led by UBC residents. The next event we have would be the next event of Women in Neurosurgery series, which will happen in February. So we will have an honor to host Dr. Sheila Singh of McMaster. So we will announce the exact date later on, but that happens somewhere in sometime in February. And also we have Dr. Karam Chandani of McGill. He will actually give us a talk somewhere in March, but again, we will announce the details of the events later on. So we are also working on the newsletter. This newsletter is going to be sent to all participants of our events and also all the speakers we had at CaMSIGN. And that's going to summarize all the events will happen in Canada regarding the neurosurgery, the important dates, the important events happening, and also the summary of important articles. And we have some interesting like passages about history of neuro-oncology or history of neurosurgery in general in Canada and in the world. So we will also send you the details of this event through that newsletter as well. So I'm not going to take your time more. I know that everyone has their own plans on the Saturday night. Thank you again, everyone, for joining us. And personally, I learned a lot from this event. The recording of the event we will post it later on our website and also on the YouTube channel. So feel free to listen to this important lecture again.
Absolutely.
Thank you, and
thank you, everyone.
Thank you very much for the opportunity.
Thank you.
I'm sure I'll see some of you at the interviews. Yeah. Bye-bye.
Yes.
Great. Thanks. Take care.
Have a good night. Thank you, everyone.
Bye-bye. Good night.
Bye.